I should be. Yep. So this talk will break into two parts, and hopefully I'll get to the end of the first part. The first part is going to be an overview of how high frequency oscillatory ventilation works, and Evan's going to talk about the jet, because they are very distinct, and it's actually really nice for me to come to somewhere where the jet's being used, like North America. But in Australia, where there's only 2 units using the jet, so it's fantastic to talk jet with people. Because the rest of the world thinks you're weird, right? All these Europeans not using the jet. So, sorry, not allowed. Yeah. And then the second part, I've just got a little brief talk, which again the people from Calgary have heard, which just shows some data that we've done and some others have done, looking at all the new ventilators on the market in terms of what sort of high frequency they're offering. And so the Calgary guys have heard this. But I think it's quite pertinent to spend just 10 minutes, 15 minutes going through these new ventilators, because there is a gaggle of them now, and they've all come out and with no evidence behind them. So we need to understand how they've been built. So as we know, high frequency is not a new thing. Does anyone know when the first description of high frequency ventilation was? Sorry? Yeah, you know from last. Yeah, do you know when? No, earlier than that. No, earlier than that. Did you have to do this for your PhD?
No.
Oh, so you're different supervisors. 1909. First description of high frequency ventilation physiologically in mammals. And it was a description of how dogs panted. And a dog that pants, so if you've got a dog and you take them to the park and you see them run around and they pant, they're initiating nature's own high frequency. Okay? So what are they trying to do? They're trying to achieve gas exchange at very fast rates and low tidal volumes. It's an efficient way to do so in a dog. So but as we know, the first clinical use of high frequency are now many, many decades old. This is not a new mode of ventilation. High frequency oscillatory ventilation is a type of artificial ventilation in which an oscillatory flow with clearly defined inspiratory and expiratory phases is generated in a lung with a frequency of at least 2 Hz or 120 inflations per minute. An oscillator, in at least the old original definition, was a device which generated an oscillatory waveform at the airway opening at least 2 Hz with active inspiration and expiration. And this is pretty important because this is something that's often debated. And using tidal volumes, at least theoretically, should be less than the anatomical dead space of the respiratory system. And often, the original ventilators were characterised by how they exhaled. Essentially, practically, as we all know, high-frequency oscillatory ventilation is a distending pressure applied to the lung, of which there's a wiggle superimposed. So it's CPAP with a wiggle. At least in the old devices, in the old system, we had 3 types of high-frequency devices. We had the jet, which I'm not going to talk about because Evan will do a better job. We have the sort of, well, at least in the sort of 90s and in the 90s, people called the true oscillators, or at least the manufacturers of those devices called the true oscillators, which had an oscillatory waveform and active expiration, and the Sensormedics is a prime example of that. We then had a group of ventilators which are really more flow interrupters. So it's fast flow of gas, and they quickly interrupted that flow, and they had a more passive approach to expiration. The Baby, the Draeger devices sort of would fit somewhere in between because of the use of Venturi effect for expiration. I'll show you at the end that this probably, at least for these devices, isn't relevant anymore. And essentially, the true flow interrupters aren't on the market. Fundamentally, for the patient, the difference is in the rate we apply of ventilation to the lung. The tidal volumes we're expecting the lung to be exposed to are obviously much lower than on a conventional ventilator. The alveolar pressure is significantly lower, and this is one of the reported benefits for lung injury. And end expiratory lung volume ideally should be normal, and it may be lower, or it could probably be lower during positive pressure ventilation. And to achieve these characteristics, we use much higher flows of gas onto the lung. Practically, a big difference is in the way the pressure and the flow waveform move down the airway. So on a conventional ventilation, we're using essentially bulk flow of gas. You get what the pressure you apply to the lung here at the airway opening is equivalent to the pressure at the end of your endotracheal tube and initiates a similar volume change because that pressure is continuing all the way down into the alveolus. So what you give is what you get. Yeah? But on an oscillator, you will have a very, very high delta P being applied to the lung at the airway opening. We see that. We set our delta P's at 20, 30, 40 centimetres of water. But it is attenuated down the system such that the alveolar level, the volume, the pressure change occurring tidally is exceptionally low. And this is a volume recording in a piglet where we've got high frequency running and then we superimpose a sigh breath with conventional. You can see here the pressure change occurring. There's your sigh breath going. You can see how the pressure is already attenuated at the end of the tracheal tube where it's not in conventional. But here's your little high frequency pressure waveform there, and you can see the volume changes occurring in the lung are very different. And there's lots of different reasons why this occurs, and these are exceptionally complicated and I think are exceptionally, essentially irrelevant at the bedside. Okay? And if you want, you can talk about these things in great detail, but I think they just make life more difficult for ourselves. What we do need to know is that the way pressure is transmitted or attenuated down into the lung with high frequency is not even across the lung. So some airways, some alveolar units will be getting a much higher pressure transmission than other ones. Okay, that will be somewhat dependent on their physical location in the respiratory system and also dependent on their disease state. And that is in some ways due to the way the pressure moves through the lung. Up here in the upper airways, you're still getting more bulk flow occurring than down here in the very distal ones where you've got different parameters occurring. And this can translate in different ways of gas mixes. And again, now I think this is very, very confusing and again, doesn't practically mean much to us in terms of, at the bedside, us understanding whether there's pendular flow and all that sort of stuff. What's more important is we need to understand that it is a complex process that's going on. And not the same throughout the lung. So before we talk about how to set up, how an oscillator works, we need to talk more importantly about how to set up the oscillation process. And this is nearly always excluded and neglected, I think, in all the literature and the textbooks and stuff. But if any nurse in our team knows, the success to high frequency is getting the patient ready to be oscillated, not the doctor just coming in and going, bing, putting the oscillator on and magically the baby's cured, okay? And we don't, especially for medical practitioners, I don't think we spend much time talking about this. We need to understand the machine and how to set a machine up. This is not the same in every machine. At least when we just had the Sensormedics, it was a big impact on the clinical care. You had to wheel something in, big rigid circuit would go to the patient, you have to take them off conventional ventilator. And it meant the machine had to be in the right place and set up in the right way. You need to think about how the bedside environment needs to be set up before you oscillate a baby. You need to think about how the patient needs to be set up before you oscillate a baby. In particular, the supportive mechanisms around the patient. So, do you need to think about the cardiovascular state of the baby before you move on to high frequency? Do you need to think about the tube and the strapping and where the tube is and whether there's a large leak? Is the baby going to cope with a rapid change in its ventilation parameters? Does the baby need suctioning? What monitoring is in place? This is somewhat less relevant now that we have good oscillators with good monitoring, but we need to have the right bedside monitoring to know what is happening to our patient, because we're attempting to make a rapid change in that baby's physiological state, clinical outcome. So, supportive care. Firstly, we need to ask ourselves, do we need to correct hypertension? If you put a baby on an oscillator who has a crashing hypertensive cardiovascular system, you will have a baby on an oscillator with a worse cardiovascular system, okay? And especially if you're going to think about aggressive lung recruitment, you need to have a stable cardiovascular system. In my experience, where we do mainly big babies, and we often deal with a shocked baby, so a system that's not just primary respiratory, but often has a cardiovascular collapse component to it, if we attend to inotropic support, volume depletion, get the best blood pressure we can and try to and optimise our acidosis management, then we don't see those babies get worse when we do lung recruitment on them from a cardiovascular point of view. But if you try to recruit one of those bigger babies with a collapsing cardiovascular system, you will just increase intrathecal pressure and make things worse for the heart. And that makes it, one, worse for the baby, and two, worse for you because you can't use your bedside measures to understand whether lung recruitment's working. If we have pulmonary hypertension, we need to be aware that when we oscillate a baby, that may get worse. Hopefully it will get better. Often the two go synergistically together. So think about this before you oscillate. Have I corrected my acidosis appropriately? Have I got the best CO2? And what CO2 am I attempting to aim for? Do I need to push my systemic pressure up to change my interaction between the right and the left heart? Do I need to normalise these sort of standard bedside parameters? And do I need to consider other adjunctive therapy? How do we achieve gas exchange in an oscillator? As I said, essentially, gas exchange is oxygenation and minute ventilation. And on a conventional ventilator, we use FO2, PEEP and I time, essentially for oxygenation, and we use rate and tidal volume PIP essentially for ventilation. On an oscillator, we have frequency, which is a measure of rate, the amplitude, which is our measure of delta P, and the inspiratory time, which is used in a different way and expressed in a different way from conventional ventilation to achieve it. And then for oxygenation, it's mean airway pressure and FO2. But of course, that's not what it really is. These things all interact more, and the mean airway pressure has an effect on ventilation. And I should really have arrows pointing down this way too, because frequency in your I time can have an effect on oxygenation. These things are more interrelated than people think. So let's talk about ventilation. As I said earlier, alveolar ventilation is rate times tidal volume. On the oscillator, it's rate times tidal volume squared, okay? Or at least mathematically it is in the alveolus. And the diffusion coefficient of CO2, this magic number which is always shown around our dCO2, is just a fancy way of describing alveolar ventilation during high frequency, okay? The way tidal volume is achieved on an oscillator is from the stroke volume the ventilator applies to the system. So the amplitude is created by a piston or a diaphragm or a series of jets or some other thing which is moving or changing the flow and the pressure in the system. And this causes the gas volume displacement and causes the chest to wiggle. And it is essentially the difference between the peak and trough swing around your mean airway pressure. So it's equivalent as your high frequency PIP and your high frequency peak. The area under the curve of your high frequency waveform is the stroke volume. So this is your tidal volume, the area under this curve, okay? So consequently, the things that will affect the area under the curve, let's see if my animation works this time, are making the curve bigger but keeping it the same width. That's changing our amplitude. That will obviously increase our tidal volume, but also making the curve wider or shorter but keeping the amplitude the same will influence our tidal volume. And this is really important because this is a difference from conventional ventilation, isn't it? Okay. So, initiation of the wiggle in the chest. How do we do it? First, we need to, when we set our amplitude, we need to consider the disease and the patient. We need to think about the mean airway pressure we're going to be using. Because at the end of the day, in most lung diseases, when CO2 elimination is a problem, the first action is adequate recruitment, not adequate delta P. There are lots of good guidelines for setting the delta P, right? Everyone has a formula they use, whether it's 1.5 times the conventional mean, twice the oscillator mean, the 1/15 of your grandmother's age divided by the number of legs your dog has, depending on the equinox of the sun. There's all these different formulas, okay? None of them they're all just formulas and people's own random thoughts. At the end of the day, what you're trying to do is get good chest wall wiggle. And for an experienced operator, often the wiggle of the chest is the right way to set delta P. And any number of formula you're given, and anyone who gives it to you in a straight face, really what you should be saying, that's just their way of thinking about how to start. And like everything in ventilation, particularly so in high frequency, what you pick is not what you will end up with necessarily. It's just something you're starting with. And the key to optimising respiratory support in high frequency is to watch your patient learn, readapt, and do something about it if you've got it wrong. Because a baby will get it right, you'll just get it wrong. Watch the chest wall. And I also feel the chest wall. Maybe if you're coming up into the lab, we can do some of that. Talk about, show the difference between how you watch the chest wall and how you feel the chest wall. I think you have to have some monitoring of ventilation when you start high frequency. I think the days of putting a baby on a ventilator without any monitoring of CO2 clearance, when you're using something that has the ability to profoundly clear CO2 when used efficiently, or profoundly not clear CO2 when used inefficiently, is indefensible. So we do have transcutaneous monitoring as our mandated measure in all of our babies, including our preterm babies. So, and we are a surgical unit, we do get preterm babies. And our nurses do put it on, we don't see burns. It depends on how you set your temperature. Now in the modern era, we use more and more respiratory function monitoring. This was much harder to do when you had the Sensormedics as your sole choice oscillator, because you had no respiratory function monitoring. Your only available monitoring is CO2 transcutaneous. I don't think you can use intermittent blood gases as your only monitoring. Fortunately now with all the ones in this room, we have respiratory function monitoring, and we'll talk a bit about that in a minute. So the next thing is the frequency. So the frequency is our other control of CO2. Okay? So if the amplitude controls the force of which the piston moves, the frequency controls the time that the ventilator is allowing the piston to move. So a lower frequency will give you greater volume displacement because of the area under the curve concept, and a higher frequency will give you less volume displacement, but you'll get more cycles in per minute. The other important thing to bear in mind is that unlike a conventional ventilator and unlike the jet, there is an interrelate. We don't set an I time and an E time. We set the frequency, the number of respiratory cycles per minute, and we set the percentage of time you'll be in inspiration and expiration. So if you have a 1-to-1 ratio, you're asking yourselves to have just as much time in inspiration as you will in expiration. If you have a 1-to-2, you're asking the lung to have twice as much time for expiration as it would in inspiration. And that can be quite important and needs to be considered in your strategies, particularly if you do have a condition of gas trapping. If you have a condition where getting gas out of the lung is a problem, not only is your absolute frequency going to be important, but allowing the lung enough time to deflate between each cycle will be important too. So I tend to avoid IE ratios of 1-to-1 if I have conditions of gas trapping. There's a lot of debate, and it happens a lot in Australia because some of us in Australia are over a 1-to-1 to 1-to-2 ratio in terms of injury and shear force stresses on the lungs and modelling of lung injury and stuff like that. I think probably in the HFOV baby, it's somewhat irrelevant whether it's 1-to-2 or 1-to-1 because of the sort of lung disease you're treating. It may be relevant for some of the actual specific devices. The frequency is generally set according to the size of the patient, the type of the lung disease, the behaviour of the ventilator. The frequency should never be set at one number in every baby in your unit, and that's how you always set frequency, because that's how someone else told you to set frequency, and that person doesn't know who told them how to set frequency, and that one can't remember where they heard it from. That's not how you set frequency. Just like you should not have every baby on an I time of 0.3 and every baby on one mode of ventilation always, unless that's the only mode you can possibly use. Because the frequency is determined by the ventilator to a certain degree, but 99% of the time is determined by the patient and the disease the patient has. generally, as we all know, we try to get the frequency right for our baby, and then we don't change it much. We change delta P, or volume guarantee if we're using volume guarantee, for minute-to-minute changes in CO2. And there's a rationale for that, because it is frequency times VT squared. You'll get more bang for your buck by changing your tidal volume. But because tidal volume is determined by the stroke volume of the ventilator, if you have the wrong frequency, you'll already be having an impact on the tidal volume. And we often wean frequency in a different way from convention. We don't use it as a way of reading rate like we do on convention. And then I'll talk a little bit about this concept of the resonant frequency in the lung, okay, which is different from the resident frequency in the lung, which is the frequency a resident says. Okay. So changes in tidal volume with increased frequency. So we all know that we have a big effect on tidal volume with different frequency rates. And if you have a fast rate frequency, your tidal volume per respiratory cycle is less, and if you have a slow frequency, it's more. We also, I think most of us know, at least those of us who are now in the older phases of our career, know that in the old days, with the original oscillators, there was a significant difference in the ability of the oscillators to clear CO2, i.e. generate tidal volume, and that was very highly frequency dependent. And we can see here the sensormetics had very efficient high tidal volumes at low frequencies, were significantly higher than the baby log when it first came out. It gets a bit more complicated than just the frequency itself and the ventilator you use. It's got to do with the lung mechanics as well. And different compliances within the lung will affect the effect frequency will have on tidal volume, because the compliance of the system will affect the transmission of pressure down the airway. So you don't get, so in a compliant lung, there's marked dampening of the pressure waveform. So at different frequencies, you can see the percentage of delta P being delivered to the lung is actually relatively low at different frequencies. But when you get down to the non-compliant, i.e. the atelectatic HMD lung, you lose that effect to dampen pressure down the airways, and the frequency you set can have a much bigger effect on the subsequent tidal volume you get than you would in, say, a term baby with a more compliant system. So we just need to be aware that when we are dealing with the babies with acute atelectatic lung disease, the frequency can have a huge effect on our delta P. That's going to be important if we think about modes like volume guarantee and high frequency. The volume guarantee setting we're going to need to use in the oscillator is going to be dependent on the baby's own lung condition, not just by virtue of the baby's disease, but by virtue of the way the disease can affect the pressure transmission in the lung. And again, this is repeating some of this data, that we also need to think not just about compliance of the system and how that affects subsequent tidal volume, but also the endotracheal tube that we're using when we're using high frequency and how that affects our tidal volume delivery, because that has a big influence on resistance. And again, we can affect the tidal volume we deliver and the degree of pressure transmission in the lung, not just with frequency and compliance alone, but by the ET tube we pick. So again, we now have another parameter we need to consider in terms of how we're thinking about how tidal ventilation occurs. So what about oxygenation? Oxygenation's easy, because all we're trying to do is get a pressure change that gives a volume change, as I said in the last talk. So oxygenation's the easy setting. And as long as we just do what Anton tells us with lung recruitment, then we're fine. Atelectatic lung. And this is just repeating this. We need to apply a certain pressure to the lung to get that lung to initiate a volume change. And I'm going to talk in the next talk about how to recruit the lung. So I won't now talk any more about oxygenation in this talk. But I'm going to come back to this concept of time constants. Just like in conventional ventilation, we need to think about the amount of time the lung is allowed to inflate and deflate. Not just because it has effect on tidal volume and all these other things I've just shown you, but because it's still the fundamental concept of time constant within the lung. We have to set our frequency, which is our determinant of I time and E time, and our IE ratio, based on what the lung needs to have to allow gas to get in and out, even though it's going really quickly, and to get a volume change, even though it's going really quickly and much smaller than conventional. And I've shown you all of this, so. But like all things with high frequency, it gets a little bit more confusing. And have any of you seen this graph before? This is like a classic high frequency graph, right? Have you all seen this? Yeah? Does anyone understand it that's seen it? When I started my PhD, one of my PhD supervisors gave me this paper, right, and said, you need to read this, and it's fundamental if you're going to do a PhD on high frequency to know this graph and be able to explain it. And I said, really, why? And they said, because if you can explain it to me, then I will now understand it, because when I did my PhD on high frequency, I didn't understand it, and my supervisor gave it to me and said, you need to understand this graph if you're going to do high frequency, and then explain it to me. This is profoundly complicated, okay, but it's kind of a cool looking graph, right? What this really means is this has got to do with the diffusion of gas in an alveolus, okay? So the way CO2 and oxygen move in an alveolus, the efficiency of the system will be affected by the lung state or the disease, yeah? So the range of pressures that you have and the ranges of frequencies that you have to be able to use on your ventilator will be affected by the lung disease if you want to get most efficient gas exchange inside an alveolus. What does that mean? That means that if you have a normal lung, you've got a wide range of choices where you can be efficient. But if you have a HMD lung, the amount of pressures and the amount of frequencies which will give you the optimum intra-alveolar gas exchange is much tighter. So this is my take on this, my sort of layman's translation. What does it mean for me at the bedside? It means I have to be much better at what I do. This is a less forgiving lung when I have HMD, RDS or atelectatic lung disease compared to a normal lung I'm putting on oscillator. I have a tighter range of mean airway pressures and I have a tighter ranges of frequencies which will be mechanically optimal for my baby. So I need to be really on the ball. That's the take-home message. Putting it together, it then comes back to how we set our frequency. We have a tight range of frequencies and a tight range of pressures to get it right. That range of frequencies and pressures is influenced by resistance and compliance. Yeah? So, we know already that frequency influences stroke volume. We know already that the time constant is going to be important in determining the frequency we need. If we need a lot of time for gas to get out of the lung, we need to use a lower frequency. We know that the lung disease and the lung size determines the time constants. But if we're outside of the efficient zone of frequency and pressure, we may be getting not just inefficient ventilation, but potentially exposing the lung to injury. So we need to understand this interaction and that there is a potential in the compliant lung, there will be dampening of the pressure waveform, while in a non-compliant lung there won't. So you get a different range of frequencies that are ideal. And in a poorly recruited lung, if we use a very, very low frequency, because of this change in pressure dampening, we can potentially expose the lung to barotrauma that wasn't there at a higher frequency. Putting this all together, we get this concept of corner frequency or resonant frequency. And this is a frequency that essentially gives you the band of frequencies that should optimise the gas exchange in the baby, if you get the other settings right, and should minimise the risk of barotrauma and shear force injuries on the lung. This is all mathematical. Okay. What it tells us, though, is that there is a range of frequencies that are right and wrong. And they are not just the same in every disease. So if you look at a baby with a lot of resistance, because here you've got a resistance curve is right down here, it's going to be a lower frequency. If you've got a baby with a compliance problem, you're going to have a more efficient, you're going to have less cranial pressure shifts if you're right here at a higher frequency. And this is what people talk about resonant and corner frequencies, which I find really confusing. But essentially what it is finding the right balance of the frequencies for the best tidal volume, best time constant application, and minimising the pressure effects that could be injurious on the lungs. So, if we have this baby, what frequency are we going to use? chemistry, you can pick it from the X-ray. Right? 10 to 12, why is that? What's the problem? Yeah. So why 10 to 12? Yeah. Why? Yeah. So this is a compliance problem. Yeah. So what does that tell us? That tells us that gas can move quickly in and out of the lung. Yeah. We want to have a lot of breaths in. Okay. And Anton will talk about this concept of fast rate, low tidal volume conventional ventilation. So we've got the ability to have lots of breaths go in and out of the lung because the lung will move quickly. And that means we can get minute ventilation with lots and lots of inflations with the least amount of pressure. So it's fitting the lung mechanics. Also, we don't want to use very, very low frequencies, even though that'll give us a bigger stroke volume and give us more CO2 clearance, because we potentially are going to have a system where the pressure is not being dampened as it goes in as much as it would in a bigger baby, and consequently we can get much bigger shifts in the lung, and that can have cardiovascular other things. So a high frequency here is appropriate for this lung because you don't need to worry about the time gas is going into the lung as much as you will in other diseases. Now, if we take the same baby a month later, what about this sort of lung? Should we use the same frequency? No, what should we use? Sorry? Like what? Yeah, or? Sorry? You will, but what else will you do? You'll increase the time the lungs are allowed to deflate. So if this is where the IE ratio might be important here as well, not just the frequency, more so than in this lung, which can inflate, deflate quite quickly. This lung, yes, the lung will have a propensity to over-distend in inflation, but the real key thing is getting gas out of this lung, right? The key is going to have the right pressure and get gas out. This will have a different pressure approach too. So if you have a 1 to 2 IE ratio, you'll have twice as much time in expiration as inspiration. If you lower your frequency, yes, you will increase your inspiratory time, but you will significantly more increase your expiratory time and may well get gas to leave the lung. The right frequency to use here depends on who you ask. What you'd pick 8, right?
Or even 10.
Even 10. So I would 8, and then I would consider if things were getting worse going down, what else could I do in this baby in North America? You potentially wheel out the jet, right? Because the jet is particularly good in this sort of disease because you have much more control on expiration. The key point is you've got same baby but different disease. Now you ventilate the disease, not your protocol. And the key thing here is allowing gas to get out of the lung by using a lower frequency and more expiratory phase. And thinking about your mean airway pressure. This is not the same approach for each of these babies. So, here is one of numerous non-evidence-based slides I'm going to give you, okay? And this is purely our approach down where we come from, and it doesn't mean you have to use it, but this is our suggested initial maximum frequencies. And again, the key word here is initial. Just because you start something doesn't mean you stay, and you can be wrong. So if we have HMD, preterm HMD, we would tend to use a high frequency that fits with the lung disease. And again, this is all based in our unit on the sensormetics. So the concept here is a high frequency. This is the maximum frequency. You may pick lower. Okay? If we're using the old baby log, we would tend to have gone lower in our initial frequency for various different reasons I'll get to in a minute. If that baby a few days later starts to get PIE, you don't have a huge problem with gas trapping here. What you have a problem with is evolving lung injury, and ideally what you're trying to do is get the baby off the ventilator, but you don't necessarily need to change your frequency strategy here because you still have a big problem with compliance and there could potentially be harm going to a very, very low frequency. Some people would say once you get established PIE with high FO2 and CO2 retention, you should consider going, this is offset a little bit. you should consider going to a very, very low frequency. And at least one of my colleagues in Hobart has published a case series where they've used the oscillator at frequencies of 5 to 7 in these really nasty gas trapping babies, and shown that there's been an improvement in FO2 and CO2 retention. I'm somewhat cautious of this, and I think this should be the initial minimum frequency. I would normally start at 8, and then if I'm struggling and I can't use the jet because we've sent them all off to repair, because we only have 4, and we have not, and this is not a joke, we have done this before, inadvertently sent 3 of them off for repair or servicing at once, and then realised we've got 1 on a baby and we can't use the jet. I would start at 8, and then if things are getting worse and I'm getting worse gas trapping and more CO2 retention, I would consider going down. And it's definitely got me out of trouble before, but I'm not entirely as convinced as some of my colleagues that this is what we should do. And there are definitely some more expert high frequency people than me around who would say they think this is a harmful approach, going to 5 or 6 in a little baby. And it generates a lot of debate when we have our workshop anyway.
Well, you're going to increase your tidal volumes.
Yeah, but I can manipulate that with my delta P. Yeah. And if I clear gas out, I will need to drop my tidal volume because I probably won't be over-distending the lung. So, yeah. But I've used it and others have used it as a get-out-of-jail card, sort of. Now, in a term baby with active atelectatic lung disease, different lung mechanics, as I showed you with the time constant. See, you don't need to use as fast a frequency. You can pick 10. That's a nice number. 10's a good number on a lot of levels. It's probably about right physiologically, and it's a fantastic mathematical number for doctors. So if a baby has MAS, and as we said in Calgary, MAS is the best lung disease ever, right? Because you can get every physiological permutation and pathophysiological permutation. So it's the best one to ventilate because you really have to know what you're doing. It depends on what your predominant factors are. If you've got a mainly parenchymal disease, then you should treat it like term lung disease. If you've got a lot of gas trapping, then you're going to need to use a slower frequency to allow for expiration to occur. Or you could try to remove the gas trapping agents. What about monitoring? No study has shown one form of monitoring is better than another, right? But things happen very fast during high frequency, especially change in CO2. So as I said earlier, I think monitoring is essential for the safe application. Can we directly measure compliance like we could do on a conventional ventilator? Practically no. From a research setting, yes, because we can measure the flow waveform and then do various analysis on it to get the compliance measure out. But because the 0 points of flow don't occur at the peak and the trough of pressure on an oscillator, we can't do simple calculations of compliance at the bedside, at least in the ventilators. So we lose that fantastic measure, which is the measure we really want, is a measure of compliance. Oxygenation, we have lots of peripheral measures. We don't have a direct measure of oxygenation, so we intermittent blood gases, but most of us are using SpO2, and some units will use transcutaneous O2. So for CO2, we have indirect measures, and we have to just be aware that these are indirect measures. They are not direct measures of the parameters we're interested in. And we have less directness than we do on conventional. Transcutaneous is the most reported measure, and it's been reported for many years and shown to be reliable during high-frequency ventilation. But the absolute number's not always the case. That's not always reliable. So it's generally the trends that we're looking at. It is obviously operator dependent, so where you cite it, we've done some work which we haven't quite published, showing that there is a difference in the reliability of, at least in Australia, of the 4 major devices on the market in terms of how accurate they are when you look at correlating with blood gases. There is differences in that, and there's potential side effects from it. So if you're going to use your device as transverse monitoring, you need to understand how it calibrates, and in effect you may not need to worry about calibration. You need to understand that the operating temperature you apply will affect reliability. So you can use it at lower temperatures, but your ability to use it reliably will go down. And there's side effects, and both Anton's group and us have described the ability to use of transcutaneous CO2 changes correlating to changes in lung volume and volume state occurring in the lung. So it can be used to track, therefore, or would infer, compliance changes within the lung. But this is a slide out of my PhD, which you probably can't see, most of you, where we looked at tidal volume measured in mil per kilo during high frequency, and TCO2 measurements for a series of babies. And what we would hope is the TCO2 and the tidal volume measures would correlate well, because that's essentially what we're trying to get, isn't it? CO2 clearance is dependent on tidal volume and rate. And we saw in many babies there was an appropriate correlation, but in a couple of babies it didn't do what we expected it to do. So that means that one of these two measures, because neither of them are the gold standard, weren't working. So just be aware it won't work in every baby, and the trend is more important. So what about directly measuring tidal volume? Because of the way gas is moving in the lungs, this is not a direct measure of absolute tidal volume at an alveolar level. They essentially will be a proxy again, and some of that will be based around the algorithm of how tidal volume is measured, the accuracy of your device, and the frequency that the device is being used at. So there's very little data that actually validates the flow sensors in our devices on high frequency mode to reliably measure tidal volume. And that data that does exist has only been done at higher frequencies above 8. So at lower frequencies, we're not quite sure. Probably is not quite as important what the absolute number is, but again, it will depend on the trend. And again, as Anton's group and ours have shown, that again, you can use tidal volume in many babies can be shown to change when you would expect there to be a compliance change within the lung, which at least infers that it hopefully is an indirect measure. And we are going to hope that it is a pretty good indirect measure if we're going to start putting volume guarantee in. But again, when we look at the chest wall wiggle versus the tidal volume being measured, in many babies there was a fairly strong correlation, but again, it wasn't always uniform in all babies. I'll talk a bit about DCO2, which I tend to use the term high frequency minute ventilation. This is more of a proprietary term. End-tidal CO2 at this stage is not able to be used in high frequency, although there is at least one group looking at distal end-tidal measurements and produce some data that suggests it might well be accurate. But it's not surprising that at least side stream end-tidal CO2 won't work, because you will never get enough time to get to an alveolar plateau, the third stage of your alveolar plateau. I think this is the important parameter at the moment, because it's the one most of us are interested in and as a way of looking at trends. So as I said earlier, the DCO2 measure is a measure of diffusion coefficient of CO2 at an alveolar level. It's a mathematically described equation from the 80s. One of the two papers is Canadian. The absolute value, again, is essentially meaningless. It's really what the trend is. And practically, I find it an easier number for me to interpret at the bedside than tidal volume, just simply because the number changes are bigger. Remember, on volume guarantee, on tidal volume, you're talking about tidal volumes of less than 3 mil per kilo. So a big change in tidal volume could occur if you went from 2 to 2.5 mil per kilo on an oscillator. That is a big volume change, effectively. But it's hard for my brain to pick up on that. More attuned brains might pick up on that. But if I see a change in something from 100 to 150, my brain sort of automatically thinks, geez, that's got to be important, right? And effectively, it is the same as what's happening on tidal volume ventilation. If your frequency is the same, the only thing that affects your DCO2 will be your tidal volume measurement, the square of that. And again, Anton and our group, you guys didn't report DCO2, did you, in Martin's team? We reported it and showed that again there was a relationship between the DCO2 value and the expected compliance state of the lung. So therefore it should be able to show trends and changes in CO2 clearance. But again, these studies are lacking. What we need is more studies that truly show that a change in DCO2 of A to B, how that trends in terms of changes in PA CO2. I'll quickly talk about volume guarantee because I know someone else is going to talk about it and is going to give us lots of important data. And we don't have any oscillators that give volume guarantee in our device. The points I want to make, I won't talk about why it might be physiologically beneficial because I assume that's going to be discussed. But I just want to come back to this stuff we know about how pressure and volume change in the lung. Okay? Frequency will affect your tidal volume because it affects your stroke volume. Yeah. The ET tube size you use will affect the degree of the potential for volume change or pressure change to occur in the lung, lung compliance and stealth will have an effect, as I showed you. So this is a bit more complicated than on conventional ventilation. And this doesn't show very well, but here we have a number of different weights, we have a number of different frequencies, and at 2.5 mil per kilo, I think, might be wrong, might be 2 mil per kilo, what expected DCO2 values we would get, okay? Now, at the end of the day, it's the DCO2 or the minute ventilation that's clearing our CO2, so that's what we need to be thinking about. Okay, and it's a bit like on conventional. The volume guarantee you set on the ventilator is only as important as the effect, as the role of volume, the tidal volume and the rate, because the rate is also important. It's the CO2 clearance we're interested in. These numbers are big changes. So if we change our frequency, unlike on a conventional ventilator, we will have a big effect on the volume guarantee settings. So if we're going to use this mode, again, it comes back to understanding frequency. Because you could set 2 mil per kilo and have a baby at 15 hertz working beautifully, and then you could change your frequency, and if you don't change your volume guarantee setting, you will get a change in DCO2 that may be good or may be bad, depending on how you change your frequency. Okay, because by virtue of changing frequency, you change your tidal volume. The volume guarantee will still be trying to do the same thing, 2 mil per kilo. But it will have an influence on your DCO. So I think last year I showed this. This is a adapted slide from Jane Pillow about, which I slightly modified on her recommendations for using volume guarantee. And she, and I, this is, and I, the reason I'm presenting this is what I think you should do too. We shouldn't pick an absolute number to start with. So we shouldn't just say every baby should be on 2 mil per kilo. Just like we should never say every baby should be on 4 mil per kilo volume guarantee. And that's all we use, because that's physiologically incorrect. We don't yet know enough about this mode. Start the baby without it if you're going to use it. Do what we know we've been doing for decades. Get the baby stable with monitoring. Understand what is going on in your baby. Get your mean airway pressure strategy right, or if you're going to do recruitment, you could argue first get the baby right, get your volume guarantee on, then do recruitment. Set the frequency, get that right. Adjust your delta P for the baby and watch your parameters. Get to a point where you think something's stable. So yes, this is the settings which give me the CO2 I want, which is what we've been doing for decades. Then think about volume guarantee. So go, okay, I've got the CO2 I want. What delta P and what tidal volume has achieved that? That should be my initial volume guarantee setting. Not something that you've been told to do by somebody. Set your delta P limits sufficient enough to allow for change. Because that's the whole principle of volume guarantees. It allows the ventilator to change pressure, but it will only do it so in the constraints you have. And importantly, note your DCO2 value. Because if at another time you change frequency, this is at this point in time the DCO2 value that gave you the minute ventilation that was right for the baby. Okay? So if you change your frequency, you will need to reset your volume guarantee to give you that DCO2 value that was right for the baby. Because you're changing all of this on the oscillator. And obviously if things are going wrong and it's alarming, you need to check your patient, make sure your tube's not blocked, all of those sort of things. And it may be that you've got your limits wrong and you need to adjust them. So that might be a different way from what you're going to say in your talk, I think. But this is one way to look at it. Do you want me to stop now? Yeah. Okay. Are there any questions? Because the next bit's just about the differences in the devices.
Any questions at the moment, guys? No? Then we'll just do a break for half an hour and we are back.
We'll have a fair bit of time for discussion after, not this little bit here, but the next two talks. And again, for the Calgary Grows, you're going to have heard all of this before. In particular, I think there's generally, it would be good to have some discussion with Anton in particular around the use of mean airway pressure approaches in high frequency. And I suspect there's going to be quite a bit of discussion around volume guarantee, because it is something that you guys are using more of than at least I know in Australia we're using and elsewhere. So I'm just going to quickly talk about the actual oscillators, and we have a lot of the representatives here, so I'm going to be, trying to tell you a little bit about each of the different devices. And I think we have to be aware that virtually all of the fundamental work done on high frequency was done in the 90s. okay? And we don't live in the 90s anymore, okay? And the 90s was very different, okay? The technology available to us was very different. It was a simple time where you just got a coffee, right? And we only had a very small number of devices on the market. We have the Sensormedics, which you either love, it's either the sound of life, isn't it? When you come into the unit, or your visual response is it's like a Dalek in Doctor Who, isn't it? If you actually look at it, it looks a bit like a Dalek, and you think, oh my God, there's baby on the Sensormedics, or the end of the world is nigh, you know. So you either love it or hate it. That was the old sort of approach. We have the Jet, which is still available. So these two devices are still readily available. We had devices like the Infant Star, which is now not available, and some people might remember that. We still have one in our lab, but we've not turned it on for 12 years or so. And it is truly a device which complies with the first rule of an animal lab, which is there's nothing you can't fix with gaffer tape. Okay, so it's held together with tape. We haven't used it because we've got more modern devices now. And then we have the BabyLog 8000, which was the later of the ones to come out, which is still available and still being sold and has some unique things which differentiate it. I won't show any data on the Jet because it is a unique entity and has its own unique place, I think. From those old devices, we have known for many years that they don't all do the same thing. You don't use the BabyLog or the Infant Star in the same way that you would use the Sensormedics. And we know that that's because there's differences in the way those devices work. Doesn't mean one's better than another, okay? And I'm going to stress that the stuff I'm going to show you isn't an implication that one device is better than another. It's just the fact that just like when you go buy a car, not every car is the same. And we knew with the BabyLog early on that there was a limitation in its ability to generate large tidal volumes and to apply high pressures to the lung, and that limitation was most pertinent when we were using settings that correlated with larger babies. So over time, we have started to use the BabyLog for the little babies, and I know in Melbourne, it's sort of if you're over a kilo, you shouldn't use the BabyLog, it's the general mantra. And if you were having a bigger baby with more severe lung disease, you would do Sensormedics because it was able to generate bigger tidal volumes and it didn't have this plateauing effect in tidal volumes. And people postulated that the differences in the performance characteristics were essentially due to the differences in the way the devices made the waves of gas and pressure that went into the lung. They were different in their design and that caused differences in the flow waves. This is the Sensormedics, this is the BabyLog, and differences in the pressure wave. And you can see here, this is a much more complicated wave, this is a simpler wave. Although importantly, at least the global measurement of volume change was fairly uniform between the two. And it's probably more complicated than this global measure. So that's where things were in the 90s, and that's how people understood devices. And it was all pretty easy, and we lived in a fairly comfortable life, just having this limited choice. And then suddenly, not that many years ago, we then got this massive amount of ventilators. They literally all came on the market within about 2 years, didn't they? At least this is the Australian ones, and I have put the Stefani on as well. So I think we may even have more than you. And at least in this, we're the same as Europe, except we have the Jet. So this is essentially what's available now. But it doesn't mean, because we've got more choice, it doesn't mean the coffee's better, right? Okay? So you can't just assume this, and I'll put it to you, that's a disgusting drink. So we need to now say, can we translate what we previously knew to what we currently know, or currently have available? So we've done some bench testing, and Peter Rimmensberger's group in Geneva have also done some bench testing looking at most of these new devices. We have not yet tested these devices' ability to generate mean airway pressure, because to do so you need to do it in a recruitable sigmoidal hysteretic type lung rather than a benchtop lung model, which is essentially a bellows of some sort or a filled volume of gas, like a gas jar, which won't have hysteresis and won't have recruitability. So what we've been interested in is, the initial question we asked was, well, if we set a delta P, what delta P does the device actually give? And And that came about because of this knowledge that the way you could set delta P on the sensormetics was different from the way you could do it on the baby log. And again, doesn't mean one device is better or worse than another, it just means that you drive it differently. And the user needs to understand that. So we tested a number of devices, so most of them are here. The VN, the baby log, I don't think we have sensormetics devices here. The Fade-In and the Leone Plus, so we have a series of European or German devices. So literally I provide anything that starts with an S, apart from the Sophie, is an English-speaking machine, and all of these devices speak German very well. Okay. And then we have the two American devices, the A and the B, and then there's a UK device, the SLE, and the SLE at the time of testing only had a 1-to-1 IE ratio. So consequently, when we tested it, we also had to run one of the other devices at a 1-to-1, because that in itself is a major influence on delta P and performance, is the IE ratio. We decided to test all of them essentially at 1-to-2, because that's what in Australia at least we will use as a default. But we've got a 1-to-1 here for comparison for the two sensormetics. And we noticed that most of the devices were able to generate, when you dialed up a pressure, they generated the pressure, that pressure. There was a linear relationship. And there's a lot of little graphs here. It's easy to see on this one. They reflect different ET tube sizes, a 2.5 and a 3, 3.5, so different resistances, and then the 3 different frequencies, 5, 10 and 15 that we chose. And we've been criticised for picking those frequencies in this paper by some of the reviewers, but they were just pragmatically to show the upper and lower range and then the middle range. And we saw a fairly linear relationship that occurred. As everyone knew, the baby log had this performance limitation in terms of the delta P it could generate, which doesn't necessarily translate to a clinical limitation. The VN was the one that interested us the most because we saw that at certain frequencies, i.e. those and ET tubes, so at frequencies of 5 and 10, the device was essentially linear, but at frequencies of 15, we saw that there was a loss of linearity at various delta Ps. There was a linear approach, and then it seemed to plateau out, at least in our test lung, and that occurred at a very high frequency with a 2.5 tube and 10 hertz, at a very high delta P, sorry. Now, that's just a pressure thing. What really it's all about is the volume you're getting with the pressure. And what this translated to between the devices is that they all had different potentials to generate, at least in a test lung, different tidal volumes at different frequencies. So if you had a delta P of X and a frequency of X, it doesn't necessarily mean you always get the same tidal volume of each device. And you can turn this 2 ways. So we found that some of the devices at very, very high frequencies were only able to generate tidal volumes equivalent in our test lung of about 3 mils. So in a bigger baby, that may be a problem. In a smaller baby, that may not be a problem. Okay? And that was generally the devices, the German-speaking devices. The English-speaking devices, just like the English world, isn't it? We're good at doing things big now, aren't we? The Germans are efficient, yeah? We found that the American and the English devices, and to a certain extent some of the German ones, at very low, turn it the other way, at very, very low frequencies, they had the potential to generate exceedingly high tidal volumes. And to the point that they were generating tidal volumes that in, say, a 2 or 3 kilo baby would be the equivalent of tidal ventilation on conventional. So we have these very differences in performances at either end that we need to understand, at least in a benchtop model. So if you're ventilating, well, next time you're intubating a Michigan test lung, you need to be aware of this, okay? Okay, and we just looked at this a bit more with the VN because it interests us. Do we have to evacuate? No. And because we were interested in this change in delta P that was occurring with frequency, and we just found in the test lung that, unlike the sensormetics, there was a relationship between frequency and absolute maximum delta P you could generate. And in this test, we set the both devices to a delta P of 90 centimetres of water, because that's the maximum both of them say that, well, at least the VN said it could produce. I suggest that you're probably not going to use that delta P. Okay, but we did it because we didn't want the machine's performance to be limited by us. And the sensormetics kind of sets 90 and it just delivers 90. The VN there was, at least in the test lung, and this is an IE ratio of 1-to-1, this is an IE ratio of 1-to-2. There was a relationship between the frequency and the delta P the device actually generated despite what it was set at. And again, this isn't a limitation of the device. What it means though is if you were going to use a frequency of 15, theoretically you may not be able to generate a delta P of 40 or 50 if that's what you need to do. So, and that's not too different from what we already know about the baby log. We've always known with the baby log that sometimes if you want to use it more efficiently, often you have to just use a frequency a couple of hertz lower. Okay, now none of this has been shown in patients. This is a bench test. And there was an influence of IE ratio here that was present in many of these devices, not so in the old Sensormedics. So they're not all the same. And again, I'm going to stress it's not a performance problem, it's just a difference in design. And we have to adapt to that, which is why we have to do the thing that doctors never do when we get a new piece of equipment, is we actually have to read the manual. Okay, because the manufacturers know how these things work and they know how to make them work. And generally they're pretty good at telling us how to make them work. We're just not very good at asking them to tell us how to make them work. And you can't just get your Sensormedics and buy your new fancy screen device and assume you're going to use it the same way. And that is really logical. You know, you don't buy your little, your big truck and then buy your little car and assume you're going to drive it in the same way. The other thing we were interested in is this whole definition of the oscillator, the flow interrupter, and in its own entity, the jet. Can we use that definition in the modern era? And we put it to you that we can't, because all of these devices, none of them have the word flow interrupting in, and none of them have the word oscillator in terms of how they work. They all do things like bidirectional jets and membrane integrated diaphragms. I don't know what that even is. Valve oscillation, expiratory valve, venturi assist. It's all very complicated and not really classifiable anymore. So we were interested in looking. Oh, I've lost a whole picture here. There's some beautiful figures that go with this, which I can put up later. It's not come across. I apologise. The reference is here. We repeated the study of Tingay, which looked at the waveforms the devices generated, both in terms of flow and pressure. And we also looked at them at different levels. So we looked at them at the ventilator, we looked at them at the airway opening, and then we looked at them within the trachea. So essentially in the test lung. So that's a proxy of what the lung should get. And we found they all ended up in the trachea with a triangular type wave. There was slight differences in the wave. The devices, the Sensormedics and the SLE, had very complicated square waves, as you can see here in this figure. The pressure wave was very square, but it had all these spiky bits in it called incisors or insures. And the Fabian, the Leone, the Sophie, and the two Dragon devices essentially produced very sinusoidal waves at the ventilator itself. So there were these two distinct patterns of waveforms being generated. And we've decided that we think the best way to describe the modern oscillator is by the actual wave it's generating in the device, because that seemed to be the two ways of classifying. That's all fantastic, and really, this is sort of an engineering. The question is, will that make any difference? And again, we don't know practically and in a biological model whether it makes difference. But the engineers in this paper, which were half of them, tell us that there possibly is some differences to having a different shaped wave on how gas exchanges during high frequency. And essentially it's because of a more complicated wave has more harmonics. And given that you've got different patterns of ventilation occurring in the lung, that it might be more advantageous to have more harmonics. But again, we don't know this. And at the end of the day, down in the trachea, most of the waveforms are attenuated to a similar thing. But at least at the opening of the ventilator, you have much more complicated harmonics and more frequencies being generated with the square wave devices than with the devices that produce a triangular wave. The interesting one again is the VM, where we saw it was the only one where fundamentally there was a change between the types of harmonics being produced in the lung as you increase frequency. It went from having a different ratio of fundamental to non-fundamental harmonics as we went up, and that may be part of the reason we saw the differences in the delta P. But again, this doesn't mean they're better or worse, it just means that they're different in how you use them potentially. And we may need to slightly tweak how we do it at the bedside. At the moment, we don't really know much about them clinically, because no one's reporting the differences in the devices at the bedside. What it means is that maybe the next generation of high-frequency ventilators will not be just high-frequency ventilation. They will be multiple frequency devices, because having lots of different frequencies in the lung means that those bits of the lung that have different, I remember I showed you that picture before, it had all the different flows of gases and pressures. You've got a different frequency requirement from each part of the lung because they have different time constants. So maybe one way is to develop a device which, instead of giving a single frequency, gives a whole bucket load of frequencies at once. So instead of saying I want 5 or 6 hertz, I'll just dial up a whole broad band of frequencies and hope that that will then result in different transmissions that's more physiologically appropriate. And this is a paper that's just been accepted. It's in a lamb model with an experimental device built in Boston in the group where Venegas did all his and showed that there were, at least in lambs, some short-term differences in using a multiple frequency way. So this is just new, but is not in any way clinically practical. So just to summarise, I hope, at least from before morning tea, that I've emphasised that in many cases the most important part of high frequency is not the ventilator, but how you prepare the patient as a patient for oscillation. There are lots of new devices around. Most of them probably are oscillators, but how we define them is not really relevant anymore. And understanding how high frequency works and how it interacts with the lung is going to be the most important thing, especially in terms of determining amplitude and frequency. And this will be especially so if we're going to start to use VG options, which are going to assume that we know how to use amplitude and frequency. So that was the end of that. Are there any questions on that little bit about the devices? Why I load the other talk? Oh, you need to load. So that was just a little quick, some new stuff.